All right, so good deal. So like Sam said, I'm a park medic in Tuolumne. I'll be talking about heat illness, which I'm really actually going to be kind of talking about hyponatremia and dehydration more than heat illness. And this lecture, it's sort of more of a, it'll be slightly advanced for BLS provider, but I always think that reaching up makes us a lot better. I used to work at Zion, so I can pretend that I'm an expert in like heat and illness and dehydration, all that stuff. And all of these, so like heat illness, hyponatremia, and dehydration can all kind of mask themselves and present similarly, and they all interact. So it's hard to say like you only have hyponatremia because a lot of times you actually have dehydration along with it. But usually the underlying problem is the major one. So we'll start with dehydration. Dehydration obviously is characterized by a low volume, usually due to a high activity level that creates water loss by sweating and low water intake. It can also be known as dehydration hypovolemia, and hypovolemia should raise your ears a little bit. The term hypovolemia, essentially it is a low volume issue. Most people think of it as like a blood issue, as losing a bunch of blood. Obviously the activation is a little bit different than this, but a lot of these people they actually can appear pretty sick, and I've been on a lot of these, and you walk up and you see them and they look really pretty bad, and it's because they are starting down the road of hypovolemic shock. And it has been kind of historically the greatest concern in outdoor activities, but they've shown through a bunch of studies, mostly in Ironmans, and there has been a study in Grand Canyon due to hikers. So we always think about dehydration, but it can also be exercise-associated hyponatremia, which we'll talk about a little bit later. It's been shown to be almost as common in some of these folks that are doing these extreme activities, which you can consider some of our hikers as extreme activities here, especially coming out of the hot places that they are. There's also been some research coming out of the military on this subject, along with blood loss, and they talk about normal saline not being great to replace blood, but again the actions are different in dehydration hypovolemia because it's fluid loss, not blood loss, so they do need the fluid. So dehydration, typically you'll see a high pulse rate. This is almost every case I've been on for dehydration, is they'll have a pulse between 100 and 130, and that's moderate to severe cases. Their blood pressure tends to be low, and you can see a 10 to 20 point drop in orthostatics. And so if people don't remember orthostatics, you're going to have them laying down, you're going to take their blood pressure and their pulse, take all their vitals, have them sit up, and you got to wait a little bit, maybe a minute or two. Usually, I think they say 5 to 10 minutes. I've found that 2 to 3 minutes is usually enough, but just make sure there's enough time for their body to kind of adjust to that new position. And then you have them stand up, and you take the vitals again after 2 to 3. I think they say 5 to 10 minutes. And you're just making sure there's not a huge drop. If there is, a lot of times it is going to be dehydration. So we think about low blood pressure. The reason for that is because they do have a low volume. So sometimes you'll see, 90/60 and their pulse rate is 120. That's because their tank is low and their heart has to pump a lot faster to get all that stuff perfusing. Sometimes you can see deep and rapid respirations with this. So it's important to get vitals, obviously, but then you go on to the history. You ask them about what they've been drinking, what their urine output looks like. A lot of times it's decreased and dark. And a lot of times these patients will call you because they have dizziness and or syncope. That's usually your first sign. They'll kind of not be feeling great. They'll have a syncopal episode, and they'll be like, I don't know what's wrong. And if you get there and they've got dizziness, syncope, and you've got a high pulse rate and a low blood pressure, a lot of times you can start with oral fluids. Definitely make them stop their activity. Sometimes I talk about this. These are some of the vitals that don't really show up in books, but sometimes you can get this dehydration breath. And if you know what I'm talking about, you're going to know. If you don't know what I'm talking about, you probably won't. But if you've ever had like a long day of hiking or a long day of climbing and you've got your buddy who's not feeling that great and you kind of smell that dry breath, sometimes you can kind of feel it on that and get a feel for it if they're not feeling that great. Skin tenting is another sign or symptom. If you pinch the skin, especially on the hand, it's less accurate the older you get. It tends to be not all that accurate, but it can be just a little bit of a hint. If you pinch a 20-year-old skin and it stays tented for a certain amount of time, you can kind of, that can go in your back pocket. That can go into your brain and thinking that maybe this is the direction we're going. A lot of these patients have thirst. Most of them have weakness. And in severe cases, you can have delirium or altered level of consciousness. And like I said, again, to stress that orthostatic changes, you can have syncopal or near syncopal with 30 beat per minute change or a systolic drop of 20 or more. Luckily, this is a really treatable condition. Even for BLS providers, usually kind of the gold standard is get some normal saline into them. I've noticed that once you go 200 to 500 cc's of normal saline, that usually will drop the pulse a little bit and pick up the BP just a little bit. And that's when you know you're on the right track. Especially in the backcountry, or you're just BLS and you don't have access to the IV fluids. You can give them a bunch of water. Usually if you get like watered down Gatorade, that's usually the best because the salts do actually help it a little bit to go into their body. If you give just full strength Gatorade, that actually is not as good as watering it down a little bit. And then usually, if you're ALS, you get 200 to 500 cc's of normal saline. If that goes really well and it starts dropping their pulse and their blood pressure starts going up, then a lot of times we'll give 1,000. Some of these patients can take 2 bags of fluid, so 2,000 cc's of fluid if they're really bad off. But usually, like I said, dehydration can be pretty solvable by either ALS or BLS. We get quite a bit of these, I think, in the valley. Sam, do you know of a bunch of those in the valley as well? Caught Sam off guard.
One more time, I was literally sneezing. It was really embarrassing.
What's embarrassing?
Yeah, I'm wondering how much you see dehydration patients in the valley.
Quite frequently, yeah. Thank you, Tom. I would say right now it's our #1 call. The Upper Falls Trail loves to be a killer for that in the Mist Trail corridor. But even here in the valley, honestly, we see that quite a bit. And people traveling a ton the last couple of days and just not, treating themselves right.
For sure. Cool. And you can kind of see my graphic there. General appearance, obviously with mild is going to be alert, a little restless, increased thirst. Moderate, it starts progressing to severe. You can have people that can't really talk that well because of dehydration. You can get muscle cramps. That's less frequent, a little more frequent with hyponatremia is the muscle cramping. Systolic blood pressure, you can see how it kind of decreases when you get to severe. Pulse rate, it goes up as you get to severe. And again, that's because we've got a low tank. We don't have enough fluid and we're trying to make up for it by pumping really fast and getting all the lower fluid out to our extremities. Cap refill, again, it can be a little bit delayed. You can do the finger test. A lot of times you can do that pinch test. Again, and we're going down to the skin, the molting, cold molting, tenting. That's not super accurate, but if you start getting a younger patient, below 30, below 40, sometimes that can be just a little hint. And I'm a big person on having a good assessment and realizing that sample is not just a checkbox. Your vitals are not just a checkbox. When you see something or you hear something and you say, hey, when was the last time you ate? And they say 7 o'clock in the morning and it's 7 o'clock at night, you probably ought to explore that and say, okay, is that normal for you? All of the sample and the vitals are all trying to give you hints as an investigator of EMS to try to figure out what's going on with this patient. And that's kind of what we're looking at with this table, clinical signs of mild, moderate, and severe dehydration. So I guess we're going to move on. Does anybody have questions about dehydration? All right, let's move on to the hyponatremia. Let me try to pull up my My next slide. And that's directly from a study from the Grand Canyon, I believe. So hyponatremia is pretty highly underdiagnosed, and it can be incredibly serious. I know in Tuolumne we've had 3 cases this year confirmed. We've had 2 cases that have been really serious. I know one was GCS of 6 when we got there, and we flew that patient out, and they did have pretty severe hyponatremia. I forget the mil equivalents per liter on her, but I know it was pretty low. So in our setting, it's typically referred to as exercise-associated hyponatremia. There's a bunch of different ways you can get there. So a lot of times, number one is the chemical imbalance. We're pretty unlikely to see a lot of these patients with a chemical imbalance and hyponatremia because they're pretty sick. We're probably not going to see like a septic patient or like a neurosurgical patient or thyroid disorder, stuff like that. But we could see some elderly patients. We could see some cancer patients that is caused or contributing to hyponatremia issue. Another action that we can get into is overhydration, and that's one where we really have to pay attention to their history. You know, somebody says that you know, I know it's hot, so I'm drinking a lot of water, and I've had 6 liters of water today. And you ask them what they've had to eat, and they say, well, yeah, I haven't really eaten anything all day. That should up your alarm bells a little bit for hyponatremia and make you say, maybe this is something different. A lot of times, and that kind of coincides with little to no salt intake. And again, it's usually pretty associated with high water intake. People hear hot temperatures and they just think water is the answer. They just start hammering on water, not realizing that salt is a big, you know, a big thing that you need to realize that goes into that equation of hydration. Or salt loss due to really heavy exercise. So a lot of our folks here are you know, they're not exactly high level athletes. So they're not going to be your Ironman folks that are just hyponatremic because they're doing extreme things. Little things can kind of seem extreme. So hiking up the Grand Canyon of the Tuolumne with a 50-pound pack is kind of an extreme event for a lot of these folks. Hyponatremia really can only be diagnosed with an ISTAT. ISTATs are incredibly expensive, and they require a little bit of specialized training. They're not all that hard to work. And I think Grand Canyon is the only park in the country that has one available to their EMS providers. And that's generally because the Desert Southwest gets just an absolute ton of these. And they can be fixed with 3% hypertonic solution. But it's really touchy because you can damage the brain very easily if you're not dead on with where this person is for their sodium. So it is characterized by low sodium, which is under 130 milliequivalents per liter. Just remember 130, I'll be talking a little bit about the Grand Canyon studies that occurred, I believe, in 1993. So, you know, when I transferred from Zion, I really didn't think we were going to see a lot of these patients in Yosemite. But again, we followed up, and I was kind of surprised that we were seeing quite a few of them, especially over backpack trips is usually where you'll see it. People start feeling a little sick, so they don't want to eat anything, and then it kind of goes down a downward spiral. This is where ondansetron or Zofran, especially for BLS providers, can help a lot, because usually they don't want to eat, but that's the thing that they need to do. They need to get some sodium into them. So if you can get a little Zofran on board and get them to eat some potato chips or to drink some you know, some hypertonic solution, a bunch of sodium. What I like to do is put some ramen noodle packets. You forget the ramen noodles, just grab the packet, put it in about a cup or 2 of water, mix it around, have them chug it, and then give them 1 slug of Gatorade or something that tastes a little better. Or you can sometimes you can mix the salt with like a Crystal Light or some Gatorade powder. Not a ton of it, just to make it kind of palatable and not taste really disgusting. So, and speaking of the Ironman studies, in 1983 was kind of when they really started going after hyponatremia, particularly exercise-associated hyponatremia. In 1983, the Ironman races were studied pretty heavily. And I think that it got published in '86, but 13% of all participants were found to be hyponatremics, so under 130 milliequivalents per liter. So that at the end of the study, these researchers decided that that was the most significant health risk for these athletes in these Ironmans. You know, they for a while we thought dehydration. We were pushing water on these patients, and I'll bring up a slide too. This is from that study. And if you look at the race guidelines, they said drink 300 to 350 milliliters per aid station. And you can see, you know, it equals like 15 to 18 liters for 50 miles. So runner number one, she's a 24-year-old med student, and she estimates her fluid intake to be 20 liters. 5 minutes post-finish, I don't think she finished. I think she ended up collapsing, and she was stuporous and disoriented. Her sodium was 123. She had seizures and semi-comatose for 36 hours. That sounds pretty similar to one of our patients down in the Grand Canyon. We didn't have the seizures part of it, but she was semi-comatose, and I think she was in the hospital, I believe, for 3 days in the ICU. So runner number two, very similar, you know, 24 liters, disoriented, confused, lower sodium, but she, this I believe was a male, did get 3% and fully alert in 3 hours. So it's important to get these guys to the hospital. It's also very important to try to get some salts on board. Like I said, that Zofran can be key. Try to get them before they become unconscious if you're a BLS provider, and ALS provider too, because we don't have 3% saline, because we don't have that ISTAT. And the biggest concern about hyponatremia is the neurologic deterioration. Exercise-induced hyponatremia, encephalopathy, which we did see in that patient in Grand Canyon. And this is due to edema in the brain that is unable to be pulled out by the salt. So it does kind of essentially swell some of their brain tissue. So I'll kind of go over the Grand Canyon case studies real quick. I don't have those on a slide, but they kind of looked at the post effects of these Grand Canyon hikers. We did have a 42-year-old female marathon runner experiencing weakness, dizziness, exhaustion, nausea, vomiting, and dry heaving. So that tells you right there, it's like, yeah, you're leaning a little bit toward hyponatremia, but it could certainly be dehydration as well. And you've got a temperature of 96, blood pressure 130/78, heart rate strong regular at 88, and respiratory rate 16 unlabored. So right there, you're thinking about it. We don't really have a higher heart rate. We have a slightly elevated BP or normal BP, and they were unable to obtain orthostatics, unfortunately. They did give a 500 bolus of lactated ringers. It did not change the condition. Usually when you give 500 bolus of fluid of normal saline or lactated ringers, that should improve the condition if it's just simply dehydration. And I know Grand Canyon has gone through, they've done a couple of things where they give some fluid, and if it doesn't fix the problem, then they lean toward hyponatremia. This was before they had the ISTATs. This individual, they did test her at the clinic, and she was 123, and it was resolved after drinking salted sports drinks. The next, so in the temperature is another thing. Hyponatremia tends to have a little bit depressed temperature. And like I said, we're always looking for those little subtle differences. It doesn't necessarily, not each one doesn't necessarily mean that this is what it is, but if you start getting all those clues, it should start adding up to a big picture. So our next patient was a 29-year-old female. She hiked to the river and back in a day, which is never advised down there. I believe it was really hot that day. I'm trying to figure out, I forget what the temperature was, but I know it was over 110. And she, about a mile up from the river, she developed diarrhea. She had muscle cramping in both legs, nausea, vomiting, dizziness, and weakness. Temperature was 96.5, so slightly depressed. Blood pressure 130/95, pretty much normal. Heart rate was 104. Respiratory rate 24. Skin turgor was good. Cap refill less than 2 seconds. Copious urination. which again should be a little bit of a sign of like, I'm not sure this is dehydration. Usually dehydration, they don't urinate a whole lot. She refused to stop drinking water. She said the last meal was 4 hours earlier and had drank 3 liters of water between the last meal. Sodium was 126. And I believe she was taken to the clinic and it was resolved again by just salted drinks. Another one, we'll just go to this one. 49-year-old female feeling tired and nauseated. At Phantom Ranch, if you guys are familiar with Grand Canyon, that is the absolute bottom of the canyon where it's extremely hot. I know this one, it was like 115 that day at Phantom Ranch. She said she wasn't feeling well. She did approach Ranger. I don't believe, just looking at it, I don't believe it was any kind of medically trained. I think it was just an in-trip ranger. And she was told to drink more water. She drank a half gallon of water in one sitting at Indian Garden, continued up the trail, and then at some point she stopped and complained of exhaustion and dizziness. And she went into a sleeping bag. The ambient air temperature was 85 degrees. Blood pressure was 150 over 100. So you can kind of think of this as, she's drinking a ton of water, right? Which is making her blood pressure go up. So a lot of times you'll see that blood pressure a little higher because they've been drinking so much water. They're actually putting way too much into the tank. Heart rate is 86. So you're thinking, well, this probably isn't dehydration because she's got a really high blood pressure and a relatively regular, maybe slightly high heart rate. No orthostatic changes, respiratory rate 18. And later that evening, she was trying to make it out of the canyon. She kept trying to go up. And later that evening, she was found at Mile and a Half Rest House, and she was unconscious. I think it was a GCS of 9. And she did have, her legs and hands were in constant non-purposeful motion and the jaw was clenched. A lot of times you can get some of the buildup of lactic acid and certain things like that that make you want to move. So sometimes, again, that's another just small clue that might tell you that, yeah, this might be hyponatremia rather than dehydration. They just want to keep moving. They want to keep moving. I don't know if you guys have ever been on a hike and then, the next day your legs are kind of restless and you got to move them around a little bit. I think it's similar to that. She was flown out. The sodium was 107. And she was sent to the ICU where they administered 3% hypertonic saline, potassium chloride for the heart, and furosemide to try to get her to pee out a lot of that excess fluid. And this stuff can affect the heart. So the EKG showed T-wave changes, and that's due to an electrolyte issue. So that can also I was hearing a buddy of mine from Zion that they had a fatality that they believe was due to heat stroke. And I think it might have been a little bit of hyponatremia as well, because it might have messed with the heart with all the electrolyte changes. And the last case study I'll point out in Grand Canyon was a 51-year-old female hiking to the river, drank quote unquote quite a bit of water that day. Legs began to give out. She reported a headache, dizziness, nausea, vomiting, and diarrhea. The next morning, she experienced 2 grand mal seizures, GCS of 7, temperature 98.4, so relatively normal. BP was 170 over 90, so extremely high. Heart rate of 100, normal sinus rhythm, respiratory rate 30, and then non-purposeful movement of arms and legs and twitching. She was flown out and had a sodium of 108. I believe she was in the ICU for like 2 weeks. A lot of times these changes can mess with your kidneys and your liver, and they do need to be seen in the hospital. Even if they recover and they feel a little bit better, they do need to be seen to double check all of their electrolyte levels. So the big symptoms here: nausea, vomiting, headache, exhaustion, weakness. Those are all very similar. Dizziness. Those are all very similar to dehydration. But some of the differences: muscle cramps are a little more common in these patients. The pulse rate can be a little bit somewhat normal. And then BP can be normal to elevated. They can have a little bit lower core temperature, or they might be feeling a little cold. And the history of the ins and outs is extremely important to try to obtain. If they've been drinking a ton of water and not a whole lot of salts and not a whole lot of food, then you can kind of start with giving them a little bit of salts. If that doesn't make them start peeing and make them start feeling a little better after about a half an hour to an hour, you might start thinking it might be something else. But usually these folks, if you give them some salts, they will start peeing a little bit more, and they'll start feeling a little touch better. And I keep hammering on the sample history and the vitals being really important to picking up clues as to what's going on with your patient with any medical whatsoever. But especially with these ones, when you start hearing that they've got a slightly depressed temperature, it's a small clue. If you find out that they've got a slightly elevated BP, that's a clue. History of ins and outs, you start hearing 6 liters of water, it's another clue. And all these clues should start hinting at the direction. Even though we don't have iStats, we start getting all these clues. You should kind of start piecing it together and saying, this might be a hyponatremia issue. So the treatments are going to be obviously restricting water intake until urination commences. Usually Grand Canyon will say if they don't have a park medic or a paramedic on scene with an iStat, they'll tell you just, give them a little salt, try to withhold water for about a half an hour and see if that improves things. If they start urinating and they start feeling a little bit better, you're on the right track. If they don't, then you might try to think about dehydration again. I love those ramen packets in about 1 to 2 cups of water and washing it down with a slug of Gatorade or giving them something else to chew on. Usually, I don't know if you guys have ever had the Gatorade when you drink it after you've done something really strenuous, and it just tastes so much better than it does if you're just kind of drinking it on a normal day. A lot of times that's because you need the electrolytes. And sports drinks are better than nothing, but they actually don't match the electrolyte depletion. Solid foods are actually better, or like the ramen packet, or if you happen to have table salt, you can put it into the Gatorade. But I really think that the potato chips or something like that, ramen packets, are going to be a lot better for actually matching the sodium depletion. In the hospital setting, they will do 1 to 200 milliliters of the hypertonic solution, 3%. And that's kind of, they've got to check it on the iStat quite frequently because they do risk shifting water in the brain that damages the myelin and nerve cells a little too quickly, and it can lead to permanent brain damage. That's why we don't do 3% blindly without an iStat. But again, all of these conditions are generally intertwined. Sometimes you will have hyponatremia with some dehydration aspects as well. So you might have to think about that. So I'm just going to check the time real quick. I got time, right, Sam? Cool.
You're good,
yeah,
Tim. This is
Tom Healy says great Pedialyte. Cool. So heat exhaustion, I think a lot of folks are pretty familiar with heat exhaustion, heat stroke. Heat exhaustion is defined as a core temperature of being less than 104, but still elevated. There is research that says that heat exhaustion essentially is dehydration with a heat component as well. So just remember, if you have any heat exhaustion patient, it's really important to start getting fluids on board. And we're thinking about heat exhaustion. It's going to be a cool, clammy skin. Sometimes it's sort of an ashen pallor, and then thirst and dry tongue. These people are usually going to be thirsty. They can be pretty nauseous at times. Again, that's where I'm really proud of this part for having Zofran available to BLS providers, at least the oral Zofran. And that isn't under the tongue. Everybody remember that. And then heat exhaustion can also produce headache, weakness, anxiety, and discomfort is another one. People will be kind of a little bit anxious about things. They'll be moving around a little bit. Sometimes they'll get dizziness and syncopal as well, and that goes hand in hand with the dehydration. Remember, we're talking, if you're dehydrated, which is kind of what the heat exhaustion is, you've got a low tank, so they just need water. So the treatment, especially for BLS providers, is just to stop the activity, get them to stop moving around, get them in the shade, If you have a vehicle available, just get them into a cool environment. If you got an ambulance or a patrol vehicle, it's good just to stick them in that air condition, get that everything blowing off onto them, the cool air blowing onto them. And the evaporative and convective cooling is effective. And then oral and IV rehydration is kind of key as well with these patients. Generally, heat exhaustion, they're going to be kind of, they'll be able to correct themselves for the most part if you help them out a little bit. And that's the difference between heat stroke and heat exhaustion. Is heat stroke, you really can't solve your own issues. You've kind of lost the ability to regulate your own temperature. So heat stroke is defined as a core temperature above 104 or greater with altered mental status. I always say ALOC because AMS to me is all acute mountain sickness being up here in Tuolumne. So altered mental status or altered level of consciousness. And untreated heat stroke, like I said before, it does result in death because the body has lost the ability to cool itself. So we're talking the outside environment. So that's where you come in and get to be a savior. And most of the time, they've actually done studies on the best way to cool some of these patients, and they have said that actually submerging them is the most effective way. And there have been studies that have shown pretty minimal benefit to ice packs on the blood vessels. If that's all you've got, then go for it. But they have showed that that's not as good as we have hoped. So the heat stroke's kind of divided into two categories. You got your classic heat stroke, which is a passive exposure to high temperatures, and then exertional heat stroke, which is hypothermia due to strenuous exercise. I'm sure that we get probably a little bit of both when it's 105 in the valley and people are deciding to hike on this trail or hiking wherever. And the heat stroke can also lead to a couple of really serious conditions. It can cause cellular damage, including organ damage to the kidneys and liver, kidneys, and brain. And then it can cause rhabdomyolysis, which is a condition where skeletal muscle tissue dies and releases substances into the blood that can cause kidney failure. So the most important thing on these folks is to get their temperature down. And how we do that is to stop the activity, obviously, trying to get them into a cool environment. And like I said, the studies have sort of shown that cold water submersion cooling to be the most effective. So find a creek. If you don't have a creek, you can dump a water bottle. Sometimes you can kind of soak bandanas or towels in water and just kind of cover them in it and make sure you keep them wet. A lot of times these folks will have altered level of consciousness, so sometimes you kind of got to talk to them a little bit and make sure they understand that you're trying to help them. IV fluid resuscitation can be key. A lot of times these guys with the altered level of consciousness, they can't really maintain their own airway sometimes. So just beware of the airway issue on that. If they seem like they can swallow and hold their airway, you might try that a little bit and just little sips. But lowering the body temperature by any means possible is critical to try to get a good patient outcome. Yeah, like I said, studies show minimal benefit to ice packs through the blood vessels. So that was a little quick. Does anybody have any questions from that? I think we're back on track, Sam.
Tim, my admiration for you increases every moment, just so you know. Thank you so much. I really enjoyed hearing the kind of the critical thinking aspect of your presentation, and to really think about that sample history. I think it's really easy for us, right? If like, oh, you were hiking and you seem sick, let me put an IV in you and fill up the tank a little bit. And we've definitely had cases of hyponatremia here in the valley that were kind of unsuspected. I think getting the history is incredibly important, and so I really appreciate that.
Yeah, I think it could be more common than we think as well.
100%. I really agree with that. And asking specifically how much water they're taking in, you can sometimes be surprised, especially with filters and stuff. People take an incredible amount of water, and that's like almost kind of mind boggling. So I really appreciate that. And I also want to acknowledge you, Tim, just in this public forum, your commitment to the EMS program up in Tuolumne. You've just done so many great things up there. And I just wanted to say publicly, thank you so much for all your work that you're doing with that.